So this is module 2 on chemotherapy drugs and different types of cancers. Now before we start, I just want to, I don't think there is an expectation of knowing all the different types of cancers and lymphomas. Lymphomas are a type of cancer which are of the lymphatic system and the lymph nodes. I don't think there's an expectation to know all the cancers and to know which drug combinations are for which cancers. That would be next to impossible. Most of that information is found in oncology protocols, and there's so many protocols it would be impossible to memorize. So try and get the general concepts of chemotherapy agents. We'll have examples of some, and we're also going to discuss the effects of chemotherapy drugs on the body as well. So chemotherapy agents are used to treat a variety of cancers, some in the hopes of curing them, some in the hopes of slowing them down and giving the patient more time, and some are used really in a palliative sense to try and shrink a tumor, for example, that's compressing on a spinal cord, but we know that it's used in a palliative way, meaning we're never going to cure this, we're just going to try and treat the symptoms with chemotherapy. It's a bit of an odd concept, giving someone chemotherapy for palliative reasons, but that is done quite a bit to try and shrink tumors and maybe try and reduce the pain because it's compressing on a site in the body, or to try and shrink a tumor that's in the brain to reduce headaches. So there's an assortment. It's not always it's often not for cure. It's often to try and slow down the cancer and give more time. Now, chemotherapy agents are often used in combination for a variety of reasons. If you use one chemotherapy agent, you often have to use tremendously high doses. And then the other problem is that the cancers often mutate and become resistant to that chemotherapy agent. When you use 2, 3, or 4 chemotherapy agents in combination, it allows you to use lower doses of each one, which will reduce the potential side effects of each chemotherapy agent, and there's lots of side effects. And it's going to stop the potential for the cancer cells to create mutations that lead to resistance of the treatment, since the cancer is being attacked at 3 or 4 different sites in cell division. Okay, so the reason why chemotherapy drugs work for cancers is that cancers are often rapidly dividing cells, and chemotherapy agents attack cell division. So they preferentially, that's the hope anyways, attack the cancerous cells in the body. And there's different different cycles of cell division that you may have learned in anatomy and physiology, whether it's mitosis or different cell cycle stages, or different cancers, different chemotherapy agents attack. So often chemotherapy is used in combination to attack 2, 3, 4 different sites of a cancerous cell division. Now remember, chemotherapy agents will also attack rapidly dividing cells of the human as well. So think of your rapidly dividing cells, and that is where you're going to get your side effects. So let's start at the top. Rapidly dividing cells, your hair. So hair follicles are rapidly dividing. So many chemotherapy agents cause you to lose your hair temporarily. The mouth. The mucosa of the mouth, which is part of the gastrointestinal tract, has very rapidly dividing cells, the mucosa. So oral ulcers, which is called stomatitis, inflammation of the mouth. And also because of the gastrointestinal tract that has tremendously rapidly dividing cells in the stomach, the small intestine, nausea, vomiting, and diarrhea is extremely common with chemotherapy agents. So the hair, the gastrointestinal tract, including the mouth. Where else do you have rapidly dividing cells? The bone marrow. So bone marrow has an incredible division rate for its cell production. So red blood cell production, white blood cell, and platelets. So they will be impacted. The bone marrow will be impacted by chemotherapy agents as well. Okay. Another organ that's affected by chemotherapy agents is the skin. Skin is very rapidly dividing. You're constantly shedding layers of skin throughout the day. So skin rashes, skin breakdown, skin and tissue healing will all be affected by chemotherapy agents as well. Now, most chemotherapy agents are given, some are given orally, which makes it easier because that means the treatment can be done at home. Some are only intravenous. Some are given directly into the canals of the brain, intrathecally. So there's a variety of different ways that you can deliver chemotherapy agents. Now, chemotherapy agents are often, especially the intravenous ones, often need special precautions so that the nurse or the doctor, the healthcare professional that's giving the chemotherapy agents does not spill or get some of the chemotherapy agents onto their own skin or tissue, since they can be very toxic to your own skin. So often they need specific ways of handling a spill and precautions of how you handle the chemotherapy agents as well. Some chemotherapy agents, in fact, that we'll talk about are what are called vesicants. So vesicants are very harsh to the tissue when they're being infused. For example, if you have an IV going and you're giving an intravenous chemotherapy drug that has the potential, that's a vesicant, meaning it'll cause tremendous local tissue damage and blistering. Okay, so a good way to remember that is vesicles are just blisters. So a vesicant is a chemotherapy agent that can cause significant local damage to the tissue if the intravenous were to go interstitial, meaning it'll go into the fluid is now leaking into the tissue as opposed to directly into the vein now. So often someone who's getting chemotherapy intravenously will end up with what's called a PICC line or a port, so that the chemotherapy can reliably get into the central venous system, as opposed to taking the risk with a peripheral IV, and we'll get into that a bit later. So I'm just taking a look at the chapter in ATI, chapter 42, and I'm going to tell you right at the start, I'm not a big fan of it, of this particular chapter anyways. I think some ATI chapters are actually very good, and others are just a mishmash of a lot of information, and it's just dumped there. So the chemotherapy chapter has a lot of information, and it's almost impossible to keep it all straight. So let's just go through some of it, but knowing that this chapter or this course is not going to make you a chemotherapy expert. There's so many chemotherapy agents. We're trying to get some concepts down about chemotherapy and the side effects that they cause when used for cancer treatment. So one of them is, and I think this is in the notes as well, below one of the slides, are the sections of the pharmacologic actions of chemotherapy agents. Then you can see that some are anti-metabolites, some are anti-tumor antibiotics, some are anti-mitotics, alkylating agent, topoisomerase inhibitors. I think what I would keep in mind is that chemotherapy agents attack rapidly dividing cells. And the hope is that it preferentially attacks the cancer as opposed to preferentially attacking the human normal cells that are rapidly dividing that we just discussed. So, and that's a fine line. Some cancers don't divide as fast as others. So they can be actually more difficult to treat because the chemotherapy agents are going throughout the entire body. It's not like they're specific to the cancer. And if the cancer isn't rapidly dividing, then it may harm the human more than it actually harms the cancer. So always keep that in mind with chemotherapy agents, that it's a fine line between treating the cancer and harming the patient with a multitude of side effects, and some of them being very serious. So I think as we go through this chapter, there's going to be prototypes of drugs in each section, and we're going to discuss the prototypes. Now, if you look through the chapter in ATI, you'll see that there'll be a prototype, and then there'll be a whole list of other drugs in that section. Again, I really think it's impossible to know all of these drugs, and as long as you know the concept of the prototype and you recognize the prototype drugs, I think you'll be doing fine. So before getting to the different chemotherapy agents, we're actually going to talk about a condition that can develop due to chemotherapy agents. So say you have a patient that's receiving multiple chemotherapy agents for say lung cancer, and we know that chemotherapy agents in general, we know which parts of the body are going to get the side effects, right? And we spoke about that already. The hair follicles, the gastrointestinal tract, the oral ulcers, nausea and vomiting, skin breakdown, and issues with the skin, and the bone marrow, right? All the cell lines that are produced in the bone marrow and the effects that they result in when they're reduced. So, for example, with bone marrow suppression, you will get a number of different side effects depending on what has been suppressed. So in general, chemotherapy drugs aren't really specific to one cell line in the bone marrow. They just kind of wipe out all the bone marrow. So whether it's the red blood cells, the white blood cells, or the platelets, they typically just suppress all of them. So what's going to happen when you have myelosuppression, bone marrow suppression? Well, the first one is you're going to be anemic. And when you're anemic, that results in what kind of symptoms? You have fatigue, you're weak, you're short of breath because there's not enough oxygenation, there's not enough red blood cells that are supplying the body with oxygen. There's not enough oxygen that can get onto hemoglobin. There's not enough hemoglobin circulating. So that's, of course, going to make you weak and fatigued and short of breath and difficulty going upstairs. All these things that you need your energy source for. You need the hemoglobin to bind the oxygen to get to the cells. What about white blood cells? Well, as your white blood cells drop in numbers, you're more at risk for infections. And remember that your white blood cells are made up of a variety of subsections. So your neutrophils and your lymphocytes and your basophils, and we can go on. But the most important one, so white blood cell is a leukocyte. So leuko is white, cyte is cell, so white blood cell is a leukocyte. The most important fraction of when we're talking about infection, is your neutrophils. Those are really important. So we always want to know what the neutrophil level is when someone's on a chemotherapy agent, or if they have, say, a cancer in their bone marrow and their bone marrow isn't producing normal levels of white blood cells. We want to know what the neutrophil count is. Because when the neutrophil drops to a certain level, we call that neutropenia. So we typically like to see the neutrophil count above 1500. Okay, so remember, your white blood cell count, your total white blood cell count is including all the different parts of white blood cells, so your neutrophils and your lymphocytes, and we like to see neutrophils above 1500. Now, as it goes lower than 1500, we'll call it neutropenia, and below 500, we will consider this severe neutropenia, and these people are at major risk for acquiring an infection. And so when we know someone is going to become neutropenic or potentially become neutropenic because of chemotherapy agents, we give them a lot of information about signs and symptoms to watch out for in terms of infection, because they're at major risk for getting severe infections in different parts of their body and then becoming severely ill or potentially dying from it. So someone who's neutropenic and has a fever, we call that febrile neutropenia. Okay, so a patient that is neutropenic is closely monitored for fevers, and when they go home, they will check their temperatures every day, and they will have specific numbers on the thermometer to check for and to notify a healthcare professional if they become febrile. And okay, so that's the white blood cell. So we spoke about the red blood cells, the white blood cells. So remember the terms. So leukopenia is just low white blood cells. Neutropenia is low neutrophils, which is a section of the white blood cells. And lymphocytes, if they're low, we'd call them lymphopenia. Okay, and often, just for some added information, often in viral infections, you can get a lymphopenia, so low lymphocytes in viral infections. Okay, and in a healthy body, when we're looking at someone's blood work and they're fighting an infection, say a bacterial infection, such as pneumonia, they'll have an elevated white blood cell count, and they'll have an elevated neutrophil count, because neutrophils are very important in fighting bacteria. Okay, and so keep in mind that when your system is knocked down with chemotherapy agents, or your bone marrow is knocked down from a cancer within your bone marrow, neutropenia is extremely important. And lastly, the last cell line are the platelets that are produced from megakaryocytes. And platelets are very important in terms of first line for bleeding, right? So if you're low on platelets, you will start to get these little red spots on your skin called petechiae, and those are little tiny hemorrhages from capillaries. You'll often have bleeding gums, because the platelets are the first part of the clotting mechanism called the platelet plug that stops the initial bleeding in a capillary. And then, of course, the coagulation system forms a fibrin clot on top of the platelets. So platelets are important for bleeding, or to control bleeding in the body. So here's some general precautions for someone who's neutropenic, but say doesn't have a fever. Because typically, if you are a febrile neutropenic, we are looking very hard for the source of infection. And the vast majority of people that have febrile neutropenia are coming into hospital as an inpatient for us to give them broad spectrum antibiotics and to do an assortment of investigations looking for the source of the infection. So febrile neutropenia is definitely a very concerning diagnosis, and we look very hard for the source of infection, and we treat them on the spot with IV antibiotics until we find that source. So, we'll take chest x-rays, we'll take blood cultures, we'll take urine samples, we'll do all kinds of tests looking for the cause of the fever. Bathing daily, so just general hygiene. Bathing daily, washing your hands, brushing your teeth with a soft toothbrush typically to prevent bleeding, because you don't want to get a bacterial infection into your bloodstream from your teeth. Cleaning the toothbrush in a dishwasher is totally fine, to make sure that toothbrush is staying clean. Preventing constipation. Why would you want to do that? Well, if you become constipated, which I'm going to tell you is relatively uncommon when you're on chemotherapy drugs, because most of them cause diarrhea, but you want to prevent constipation, because if you become constipated, you may develop hemorrhoids, or you may develop an anal fissure, a tear in the anal canal, which will bleed. And that will put the stool in contact with blood. And that could potentially put bacteria into the bloodstream. Okay? So avoiding tampons and douches. Those are foreign. So foreign bodies in the body when you're neutropenic is a very bad idea. If they become infected, and that infection travels to the bloodstream, that could quickly take over the body. because the body doesn't have the ability to fight back with its immune system. Avoiding sharing things with people. So whether it's a glass, a fork, or anything, you really avoid sharing things with other people that could potentially give you an infection. Avoiding live plants and flowers and things like that. You want to avoid things that potentially have bacteria or fungus on them. And that comes to the next one, avoiding your pet and having to clean up after your pet. So the litter box for your cat, or picking up after your dog, those things are done by someone else. And definitely avoiding crowds. So neutropenic patients are strongly encouraged not to walk in malls, not to go in crowds, because of the risk of acquiring an infection. And typically, neutropenic patients, so when do you become neutropenic? So there's a term called the nadir, N-A-D-I-R, and usually after getting, and the nadir is the low point of the bone marrow suppression from the chemotherapy drug. That's the lowest point, and then the bone marrow picks back up and starts producing cells again. And usually the nadir is around, after receiving chemotherapy, is usually in the range of 7 to 10 days. So a week to 10 days after you've had your chemotherapy is when we would expect the low point of your bone marrow suppression. So we always ask people, when did you receive your chemotherapy drug? Because that gives us an idea of when the low point, when the nadir will happen. Okay, so this is just a continuation of neutropenic precautions. Washing your hands, making sure the kitchen is clean, the counters have been cleaned up after cooking, avoiding eating raw foods if you know that you're neutropenic, cooking your food, especially meats, all the way through to avoid acquiring any bacteria that's in the meat, and refrigerating your food after. So if you have leftovers, you're going to refrigerate them immediately. They're not going to sit out for the day. So remember, the typical neutropenic patient is 7 to 10 days after receiving chemotherapy. So they're typically at home. And these patients are given think of all the information they've been given in terms of how to avoid infection, how to keep away from other people, avoid crowds, the cooking, the taking care of their pets, all the things that they need to avoid. Plus, they have to be very aware of their body's symptoms. So any symptoms or signs of infection need to be reported very quickly. And in particular, a temperature, so a fever. Now, what happens if someone goes to the hospital and they were told, say, a day or two before that they were neutropenic, meaning their neutrophil count is below 1,500? They arrive to the hospital and they tell the triage nurse that they've had a fever of 39 at home. Well, that's going to trigger a very fast response from the healthcare team. So if the healthcare team knows that someone's neutropenic and they have a fever of 39, it's almost guaranteed this person is going to be admitted for IV intravenous, broad spectrum intravenous IV antibiotics, and a complete workup of all the different sites looking for infections will be taken. So, as I said before, blood cultures, urine cultures, chest x-rays, a variety of different types of blood work, looking for infection, and then immediately starting IV antibiotics after we've taken our tests, and monitoring the patient closely in hospital, monitoring the vital signs, the blood pressure, the heart rate, and the temperature, and also their symptoms as well. So some people come in with very little symptoms. They just have a fever. They haven't developed a cough yet, or they haven't developed abdominal pain. And they still end up being admitted until we can figure out the source of the fever in this neutropenic patient. So the next slide is on temperature. So this is just giving you an idea of the information that would be given to a patient in terms of when to contact their healthcare provider. So a fever of 100.4 for more than an hour, or you have a fever of 101 or higher once. So the first one is referring to you've checked your temperature twice and it persists at 38 Celsius. The second one is, okay, no, I just got one reading and it's over 38.3. Okay, both of those are reasons to seek medical attention now in the setting of neutropenia, or you suspect that you may be neutropenic because of when you were given your chemotherapy drugs. Okay, so this next slide in terms of contacting your healthcare professional or your healthcare provider. So these are all the reasons, and there's probably more, why you would contact the hospital or your healthcare provider with these symptoms, especially in the setting, in the setting of a fever, you're going to contact anyways, whether you have these symptoms or not. But look at these symptoms as well, with or without a fever. So if you have a new cough, sore throat, new mouth ulcer, sores, diarrhea, redness or swelling on any place in your body. So say redness or swelling on your arm where the IV site used to be. That could be now a cellulitis and a bacterial infection of the skin and tissue. That can spread very quickly with a weakened immune system. That you're planning to travel somewhere. Well, if you're planning to travel and there's a possibility that you'll be neutropenic while you're traveling, that needs to be discussed. What accommodations you're doing for that. Any pain in your abdomen or in the rectum. Burning on urination can be an indication of a urinary infection, a bladder infection, or a kidney infection. Fatigue, forgetful, confused, that can be infection. That can be a concern for sepsis, or something is going on in the neurological system, your brain. So potentially a meningitis or something else concerning. So any hint at a possible infection needs to be reported. Plus, of course, those fixed numbers for a fever, whether you have symptoms or not. Okay, so let's go on to talk about cancer and chemotherapy agents. And neoplasia, which you can see on this slide, is just another term for cancer. Let's briefly talk about the slide image here. So this image is showing you a very specific cancer treatment, monoclonal antibodies. And you may have heard of this, you may remember this term from a drug that we were talking about not long ago called basiliximab. Remember, it ends in MAB, so it's a monoclonal antibody. And that particular drug was an immunosuppressant because it inhibited interleukin receptors. So it was used to prevent renal transplant rejection. You can also make monoclonal antibodies in a lab that can attack cancer cells. So cancer cells can be studied in a research lab. Specific antigens can be found on the cell membranes of the cancer cells, and then they can produce monoclonal antibodies, almost like direct bullets that will attack those specific antigens with a specific antibody. And once you bind an antibody to an antigen on a cancer cell, then the body recognizes that complex, that antibody-antigen complex, as foreign and destroys it. So it can either destroy it with inflammation, or it can destroy it with phagocytosis, and the cell just the cancer cell dies. Okay, so monoclonal antibodies are a very specific cancer treatment to specific cancers. So we'll talk a bit about those later. What we're going to talk about now are really non-specific chemotherapy agents that try to blast away at rapidly dividing cells in different ways, typically to attack the cell division of the cancer cells. So they're non-specific. They're going to attack the cancer cells. They're going to attack rapidly dividing cells of the body. Anything that has rapid division. Okay? And because cancer cells typically have very rapid division, we hope that the chemotherapy agent preferentially attacks the cancer compared to the hair follicles and the GI tract, and the bone marrow and the skin of the patient. So it's a bit of a fine balance of how much chemotherapy agents to give to attack the cancer, but not to kill the patient. Okay? So remember, when we're talking about chemotherapy agents, each one will probably have a very specific side effect, or some of them will anyways. But in general, chemotherapy agents, what do they do to the normal cells? Well, they're going to suppress the bone marrow. They're going to give you a lot of gastrointestinal symptoms of nausea, vomiting, and diarrhea, potential bleeding. They're going to give you oral ulcers and mucositis, which is inflammation of the oral mucosa. You're going to have general fatigue and loss of appetite. That's typically from the chemotherapy drug itself on the appetite, or even the cancer can sometimes, you'll lose your appetite. Fatigue is often in association with anemia. It's going to put you at risk for infections due to your lowering of the white blood cell count. And you'll see that some will have specific side effects that will stand out as special to those chemotherapy agents. Okay, so let's just talk about the groups a bit. So there's different ways that cancer cells can impact, the chemotherapy agents can impact cancer cells. And the first group, and I don't think you need to memorize specifically each group and every drug in the group. I think that would be impossible. There's just too many drugs in each group. And I think it's reasonable to remember the prototypes. So in the first group, the antimetabolites. So these drugs stop cellular division of rapidly dividing cells. And it's usually because they're trying to inhibit some kind of function within the cancer cell that it requires to divide. So a very common one in this drug, and you may have heard of this drug before, is methotrexate, and we'll talk about it more. It's an anti-folic acid drug. So it inhibits the function of folic acid, which then stops cellular division in the cancer. And the other one is azathioprine. So that's an antimetabolite. It becomes it fakes itself to look like a purine, which then gets into the DNA and destroys the cancerous cells because it actually isn't a purine. So It's an anti-metabolite as well. Okay, and we'll talk a bit about that one too. And then we come to what are called anti-tumor antibiotics. And again, I don't think you need to memorize the fact that they're specifically antibiotics, but so they can block RNA or DNA synthesis and also protein synthesis. And the two prototypes in this group are doxorubicin and bleomycin. Okay, and we'll discuss those later. Antimitotic agents, so they stop cellular division, and this is the vincristine vinblastine group. So just consider vincristine and vinblastine essentially the same, and they'll give very similar side effects. The next group are alkylating agents, and they basically alter the structure of the DNA, which grinds the cancer cell to a halt. Okay, because it's not the normal structure anymore. And the two in this group that we'll chat a bit about is cyclophosphamide and cisplatin. And then lastly, there's the topoisomerase inhibitors, and we're not going to talk about this one too much at all. Okay, so let's talk about alkylating agents, and the prototype for this is cyclophosphamide, a chemotherapy drug. The other one that you'll see that we mentioned earlier was cisplatin. There's another one, chlorambucil. I think if you're recognize, oh, they all start with C. There's a good way to remember them. But I think if you recognize that cyclophosphamide or cisplatin are chemotherapy agents, I don't think you need to put them in a category that of those 5 groups. I think that is likely too much memorizing and information that you probably don't need. And you'll see the indications there. Again, I don't think memorizing every indication for a specific chemotherapy agent is necessary. So whether it's Hodgkin's or non-Hodgkin's lymphomas, we can chat about those. Those are lymphomas. Hodgkin's lymphoma, people may have heard of. It's relatively common. It's in younger people. It's a lymphoma or a cancer of the lymph nodes, often appearing in the neck and the chest, often in young people, and very, very treatable. Non-Hodgkin's lymphoma tends to be it's a lymphoma or a cancer of the lymph nodes and the chest and the abdominal lymph nodes typically, and it's often in slightly older people in their 50s, 60s, or 70s, and not necessarily as treatable as Hodgkin's lymphomas. Okay, when you see the term leukemia is basically cancer of the blood cells or of a bloodline. So leukemia, so Luke is white, so leukemia is cancer of, so some kind of cancer of the blood, and what about the blood? It's the white blood cell. So it's a white blood cell cancer. Okay, so you can have AML, which is acute myeloblastic leukemia. You can have CML, which is chronic myeloid leukemia. So just different cancers of the white blood cell. And then on and on with the different cancers. I certainly wouldn't memorize those. So how does cyclophosphamide work? So it binds DNA and forms forming cross-links that prevent the synthesis of the DNA. Okay, so it's blocking DNA synthesis. So I think it's just reasonable to remember that it's stopping cell division, right? So keep it simple. Don't memorize exactly that. It's blocking cross-links. No, it's blocking cellular division. What's the side effect? Well, the main side effect is going to be the strange one, right? So remember the strange one about each drug, because the other ones they're almost guaranteed. So look at nausea, vomiting, diarrhea. That's almost every chemotherapy drug. A lot of them are toxic to the liver. They give you a hepatitis. Anorexia is loss of appetite. All of these drugs you lose your appetite with. Weight loss, Yep, because you can't eat. You've lost your appetite. Stomatitis, well, that goes with the nausea, vomiting, and diarrhea. You have oral ulcers and you have inflammation in your mouth. Hair loss, very common with chemotherapy drugs. Jaundice is because of the hepatitis that it causes, and you have bilirubin in your bloodstream, making you look yellow. Bone marrow suppression, again, a very common side effect of chemotherapy drugs. But look at this, the one that stands out, and you won't see it with other chemotherapy agents, and that's hemorrhagic cystitis. So a bleeding bladder. Cyclophosphamide gets, it gets secreted by your kidneys, gets into your bladder, and irritates the bladder wall and causes a hemorrhagic cystitis. So you're urinating blood. Okay. Contraindications, almost all of these chemotherapy agents would be contraindicated in pregnancy. If you can imagine giving a chemotherapy drug to a rapidly dividing fetus, that would be very harmful to the fetus. Severe myelosuppression, well, if you have some kind of a condition where you already have bone marrow suppression or myelosuppression, then you wouldn't want to add cyclophosphamide to it. So in terms of nursing responsibilities, definitely monitoring for this hemorrhagic cystitis, asking, are you urinating, are you urinating blood? Are you passing blood clots? And also advice on neutropenic precautions. Okay, so we're going to talk about this this treatment for hemorrhagic cystitis related to cyclophosphamide. Okay, and it's called Mesna. But before we get to that, I wanted just to briefly mention cisplatin, which is the other alkylating agent. So I would just know the term. So cisplatin, right? And what's the main side effect of cisplatin? Well, plus all the other things it does, the main side effect, the bone marrow, the mucositis, the hair loss, it's very hard on the kidneys, okay? And it's also very hard on the ears. And you'll find, and this is going to be a recurring theme, that any drug that's typically hard on the kidneys is often very toxic to the ears. And cisplatin is no exception. It's toxic to the kidneys and it's toxic to the ears. So you can have renal failure, and alongside with that, you can have hearing loss and tinnitus, ringing in your ears. Okay, so those would be the questions that we would want to ask someone who's on cisplatin. Do you have ringing in your ears? Do you have hearing loss? And also to monitor their kidney function. Okay, another common example, I can give you quite a few, but another common example is aminoglycoside antibiotics. They're hard on the kidneys, they're hard on the ears. Aspirin. High doses of aspirin is hard on the kidneys, and also it'll give you tinnitus, ringing of your ears. So there's many examples, and the reason is that the kidneys and ears, when the fetus is developing, have very similar cells, and so drugs that impact the kidney also impact the ears. Okay, on to Mesna. So it's a treatment for hemorrhagic cystitis related to cyclophosphamide. So it actually binds the toxic metabolites that are secreted in the urine, stopping them from damaging and inflaming the bladder wall. So in a way, it's a treatment that's given to prevent the side effect of the cyclophosphamide, right? To prevent the hemorrhagic cystitis from cyclophosphamide, which is a significant side effect to cyclophosphamide. So that's why this medication is available. Okay, so methotrexate. So this is a drug that's used for many things. We use it in an assortment of cancers that you can see listed there, but we also use it to purposely knock down our immune system um, with autoimmune diseases like Crohn's disease, ulcerative colitis, systemic lupus erythematosus. It's actually used in some countries and jurisdictions in specific doses to terminate. So it's an abortion drug, so termination of pregnancy. So it has a variety of uses. In this case, we're talking about it in terms of a chemotherapy agent to stop rapidly dividing cells. In autoimmune disease, we're talking about it because it suppresses the immune system and suppresses the bone marrow, so you can control autoimmune diseases. And in terms of terminating a pregnancy, well, it stops rapidly dividing cells, and that's what an embryo or a fetus is. It's a rapidly dividing organism, right? So it blocks the enzyme that converts folic acid to another form of folate. So folate is required for cell division and DNA synthesis and repair. So again, so that's why it's called an anti-metabolite, because it's blocking the production of folate, and folate is the metabolite. So because it's blocking that, it's stopping cellular division and slowing down rapidly dividing cells such as cancer. And what are the big side effects with methotrexate? Well, with chemotherapy, it's going to start to get old because you're going to hear the nausea, vomiting, diarrhea. That's the gastrointestinal tract that has rapidly dividing cells. They're all shedding and dying. Stomatitis with ulcers in your mouth. You can have bleeding in your bowels because of all the inflammation and tissue breakdown. Of course, bone marrow suppression. It's definitely a teratogenic, so it would be toxic if given to a pregnant woman. Say someone was taking it for lupus or Crohn's disease or something other than cancer. You wouldn't want them to become pregnant at the same time while on methotrexate. Okay, and the big one to remember also with methotrexate is hepatotoxicity. We're going to monitor liver enzymes if you're on methotrexate for any condition, including cancers, because it's toxic to the liver, okay, like many drugs. So contraindications, well, of course, if you have bone marrow suppression, you're not going to take more of something that's going to suppress it even further. And also use of other drugs that are very hepatotoxic. You wouldn't want to add another one such as methotrexate. So methotrexate is usually given weekly. We typically encourage people to drink a lot of fluids to maintain hydration and to clear the drug renally in the kidneys. Advising on precautions in terms of becoming neutropenic 7 to 10 days later. And also there's an interaction between non-steroidal anti-inflammatories and methotrexate. So I mentioned to you that methotrexate is used for a lot of inflammatory conditions, autoimmune conditions, and one of them is rheumatoid arthritis. And people take non-steroidal anti-inflammatories all the time for rheumatoid arthritis, and they're also prescribed methotrexate to slow down the autoimmune disease. So non-steroidal anti-inflammatories can be hard on the kidneys. They reduce kidney function as one of their side effects, and that reduces the secretion or excretion of methotrexate, causing a potentially elevated level of methotrexate. And that's why there's a relative, try to avoid taking them together because you can get elevated levels of methotrexate if you're on non-steroidal anti-inflammatories or if you're taking them together. Remember, the other one in this group of antimetabolites is one called azathioprine. Again, it's used for an assortment of things. It can be used as a cancer treatment to stop rapidly divided cells. It's also used in Crohn's disease and ulcerative colitis to reduce the autoimmune effect of those diseases. And again, with azathioprine, what's the main toxic side effect of azathioprine? Hepatotoxicity. Okay, so we're on the slide about leucovorin. So just before getting to leucovorin, I wanted to mention that in your ATI, they don't list azathioprine. At least I don't see it. But remember, azathioprine is also called mercaptopurine, just to add a bit of confusion to the whole thing. So you'll see that under antimetabolites that you'll have methotrexate and you'll have mercaptopurine, which is azathioprine. And again, I want to stress to you that I wouldn't spend your time memorizing all these different ones. Just understand the prototype ones. Okay, there's too many, and they all basically do very similar things, and there's no need to memorize every name in this ATI chapter. Okay, so leucovorin. So leucovorin, so leuco is white, is again white. So leucovorin is the rescue medication. So all leucovorin is folinic acid. All right. So it's just the rescue medication if you want to treat a patient that's had too much methotrexate and they have severe bone marrow suppression. You can treat them with leucovorin. Okay, so this is really specific to methotrexate. It provides folic acid to the system to reverse some of the side effects that methotrexate has had by blocking folate conversion. So there's really no side effects to this. There's only an upside, right? So it's going to help the healthy cells of your body recover from being affected by the methotrexate. Okay, so remember leucovorin almost as a rescue medication for methotrexate. Okay, so let's look at another chemotherapy agent. And remember, the indications, you can look at them, don't memorize them for this particular drug or any other drug. It's a bit of a waste of time. In fact, in a month or two or next year, the indications for this chemotherapy agent may have changed or altered, or the protocols may be different. So I think just looking to see that, yes, it's a chemotherapy drug. So inhibits DNA synthesis. Okay, well, so in a cancer cell that's rapidly dividing, that's potentially a very good thing, just like other chemotherapy agents that we've discussed. The other one in this group, well, doxorubicin, daunorubicin. Okay, there's another one in this group called bleomycin, and those are two that we'll just talk about. I think I'd just spend my time remembering doxorubicin, but if you wanted to remember one other, it would be bleomycin. And you can see the indications there, the actions we discussed. The main side effect of doxorubicin while you're treating someone's cancer is congestive heart failure. So cardiac injury directly from doxorubicin, and you can get abnormal rhythms of the heart, and you can reliably cause someone to go into congestive heart failure if given enough doxorubicin. And that's why when doxorubicin is given, the entire amount is always kept track of during the course of a treatment of chemotherapy. And even later, if you were to get more doxorubicin, they would also include doxorubicin that you'd had in the past, because it's very additive. And there's charts that are available that tell the healthcare providers this amount of doxorubicin will give you this percentage chance of leading to heart failure. So it's a direct cardiac toxin. Okay. Now, it'll also cause all the other things that we've spoken of before: the nausea, vomiting, the oral ulcers, bone marrow suppression. So significant bone marrow suppression with doxorubicin or bleomycin. So we'll definitely want to monitor for neutropenia 7 to 10 days later. The gastrointestinal tract is hit hard with these drugs, so they often have to be given antiemetics like ondansetron to control the nausea. Sometimes we'll give corticosteroids like dexamethasone, which can also, those are powerful anti-inflammatories, so they can also help appetite and control nausea. These drugs can cause severe tissue damage if they extravasate, meaning if they leak out of the vein into the local tissue. They can be vesicants and destroy the local tissue. And if that were to occur, you obviously stop the drug completely, and people would, healthcare providers would need to be notified of this if these drugs extravasated into the local tissue. Okay. Okay, so we got a bit off track there, but so contraindications. Well, heart disease in itself, if you have congestive heart failure, you're likely not going to receive doxorubicin because it has a good chance of killing you. Pregnancy for sure. Myelosuppression, well, these drugs are going to hit the bone marrow very hard. So if you're already myelosuppressed, and that includes thrombocytopenia, then you're not going to receive doxorubicin. Nursing responsibilities. So the total medication received in the patient's lifetime is calculated and kept track of due to that congestive heart failure. Okay. Neutropenic precautions like most chemotherapy drugs, renal function, liver function tests. They get regular ECGs to look at the rhythms of the heart because of its toxicity. Okay, monitoring for infection, that would go along with the neutropenic precautions. And it can turn your urine a bit red-orange for a few days. Okay, so what side effect do I take away from doxorubicin on top of all the typical side effects of a chemotherapy agent? It gives you congestive heart failure if taken enough of it, and it can turn your urine red or orange. Those side effects are outliers, so I would remember those. Okay. Now, bleomycin is very similar, except its main side effect is pulmonary fibrosis, so scarring of the lungs. Okay, so it's in the same group as doxorubicin. It behaves very similarly, except its main side effect, it hits the lungs instead of the heart, like doxorubicin, and it causes scarring and permanent damage to the lungs. Okay, so another group They all start with a V. So these are the vinca alkaloids. Don't need to remember that. But vincristine, vinblastine. Again, chemotherapy agents. You can look at the indications. I don't think you need to memorize them. And what they do is they disrupt cellular division. So the process of mitosis is disrupted, which leads to cellular death. Okay. The adverse effects here, the big one, neurotoxicity. Okay, that one's different than the other chemotherapy agents. There's very similar side effects like the nausea, vomiting, anorexia, stomatitis, myelosuppression, all that. And also the fact that these are definite vesicants. You do not want these to leak into the surrounding tissue from a blown IV. So these would often be given with a PICC line or with a port that we'll talk about. But remember, it's the neurotoxicity. So that's one of the symptoms and signs that will often be checked for when being given this group of chemotherapy agents. Okay. The contraindications. I don't think there's a lot of value in trying to memorize the contraindications of a chemotherapy agent unless it really stands out. So let's just, how do we monitor for neurotoxicity? So with these particular agents, we would want to know, do you have any pins and needles? Do you have any sensory loss in your feet or your hands? Are your reflexes absent? Are you having any difficulty with bowel movements or urination? That can be nerve damage to the bowel or to the bladder. So those would be questions that would be asked of the patient. And then there would be an exam, of course, to check for any signs such as reduced sensation or reduced vibratory sense of the skin. So neurotoxicity is really the big one. And the second one is it's a vesicant. So leaking of this drug into the local tissue will cause a severe amount of local tissue damage from this drug. Okay, hydroxyurea, again, another chemotherapy agent. I'm sure they all start to kind of mesh into one whole chemotherapy agent. But if you remember the concepts, the general concepts of chemotherapy, and not specifically about whether it's in the G1 phase, or just understand that it's affecting the cancer and the body and how it's affecting the body and the side effects that come along with these agents. So there's the indications. The action, again, interrupting DNA synthesis. Adverse effects of hydroxyurea. So just through history and having used these medications hundreds of thousands of times, it's very predictable which drug is going to cause which side effect. And you wouldn't want to choose 2 or 3 drugs that have very similar side effect profiles. Otherwise, if they all had hepatotoxicity, you'd destroy the liver. If they all had severe bone marrow suppression, you would annihilate the bone marrow. So that's partly why drugs are combined together, to minimize side effects and to avoid hitting one organ too hard. Okay. So with hydroxyurea, the big side effect above all is bone marrow suppression. Okay, so lowering of white blood cell count, which can lead to neutropenia, which is extremely important to advise in terms of fevers, bleeding gums, anemia. So think of the 3 cell lines that bone marrow produce. That will give you the signs and symptoms that can occur, and that's what you would advise the person, right? So the bruising and bleeding gums, well, that comes from low platelets. Avoiding crowds and sick people, that comes from the neutropenia. That advice comes because of the neutropenia. Now, the main side effect of this drug is bone marrow suppression, and in this particular case, it can last a long time. So it's the usually it's the 7 to 10 day post chemotherapy where you get your neutropenia. This one can last for many weeks. Okay, so we've spent a bit of time, we're on the tamoxifen slide, by the way. We spent a bit of time talking about cytotoxic agents. So agents with their primary intention of destroying cancer cells. And they do it through, stopping cellular division mainly, inhibiting mitosis or binding into the DNA and RNA and making a mess of cell division. And those are all the drugs that we just finished talking about. But there's other groups of cancer drugs to try and either slow down the cancer or combine it with cytotoxic agents. And these would be non-cytotoxic chemotherapy agents, meaning the main intention isn't to destroy the cancer cell directly. By the way, this is page 347 of ATI that I'm looking at. And so the non-cytotoxic chemotherapy drugs break into categories. So there's the hormonal agents, and so those would be agents that will somehow address hormones that are circulating in the body that may be stimulating a certain cancer, such as breast cancer or prostate cancer. Those are both very hormone sensitive cancers. And if we can inhibit the estrogen or the testosterone in certain cancers with drugs, it slows down the growth of the cancer. And we'll come to an example of that. The next one is biologic response modulators. Well, we've already spoken about those before. Those are things like interleukin, which are sometimes used in certain cancers. Those are immunostimulants. So you're giving a drug as an injection or IV to ramp up the immune system to attack the cancer, right? And lastly, the targeted anti-neoplastic agents are just as it says, they're targeted, so it's typically referring to monoclonal antibodies. So it's those monoclonal antibodies that are made in a lab, and they directly attack an antigen or something on the cancerous cell to destroy it without actually destroying normal tissue in the body. Okay, so before getting on to tamoxifen, let's go through, because I think these can be confusing, this chapter, but I think these can be confusing. So let's go on to hormonal agents and listed under prostate cancer. So prostate cancer is a cancer that's extremely sensitive to circulating testosterone. It actually grows faster we've discovered with circulating testosterone in the male. So we've come up with agents that either reduce production of testosterone, or they block the action of testosterone at the prostate. Okay, so if we look under these drugs here, so the first one is leuprolide. Okay, well, what does leuprolide do? Well, it's a GnRH agonist. So remember, GnRH is the hypothalamic pituitary hormone. So this is a GnRH, a gonadotropin releasing hormone agonist. So now you're going to say, well, so hang on here. If it stimulates the release of FSH and LH, and that's going to stimulate actually the production of testosterone in males, right? So how is that going to reduce testosterone? And That would be a very good question. But actually what happens if you continually stimulate with leuprolide, the pituitary gland, it actually stops, it stops being stimulated very quickly. So the leuprolide goes to the receptor and it stimulates and stimulates and stimulates and stimulates these the receptors, but then the receptors say, you know what, I can't be this stimulated, I'm going to shut down. And by shutting down, it actually reduces FSH and LH, which then reduces the production of testosterone. So it's like the overstimulation is what it does, and it finally shuts down FSH and LH and then reduces testosterone production. Okay, what about the next one? Androgen receptor blockers. So definitely the prototype for this one is flutamide. So flutamide is just what it says. It's an androgen blocker. So it's a androgen is the male hormone, testosterone, and it blocks it at the receptor. So it stops it from performing its stimulation at the receptor. Okay. And lastly, the other one I don't think is as important, Degarelix. We don't use that one very often. And this basically is an inhibitor of GnRH. It's an antagonist, and it blocks FSH and LH release, which then also, so it's kind of weird because when you stimulate too much with a GnRH agonist, such as leuprolide, or if you block it too much, you get the same effect. Okay, so hopefully that makes a bit of sense with those prostate cancer medications. So essentially, what you're using these for is really to reduce overall testosterone or to be an androgen blocker, so that even though you have the testosterone, you're blocking the receptors. Okay, so these would definitely be used in the setting of prostate cancer. Now, the other option before these drugs was to have your testicles removed because that's where testosterone is made. So it wasn't that long ago, 15, 20, 25 years ago, that was very commonly done with prostate cancer. You'd have an orchidectomy, right? Your testicles would be removed to lower testosterone levels. So now what happens when you suddenly stop testosterone production, or you stop testosterone from getting to the receptor? So I'm talking about this group as a whole. Well, you're going to get instant male menopause, right? So you've blocked testosterone, so you're going to have hot flashes. You're going to have reduced sexual desire, decreased libido. You're going to have erectile dysfunction, right? Because testosterone is needed for all those activities. Why are you going to get gynecomastia with these drugs? Well, you're blocking testosterone, so and males also have a bit of estrogen circulating in their body. So if you're blocking testosterone, you're magnifying the effects of estrogen at any particular site. And at the breasts, estrogen makes them grow. So you can get small breasts, or males can get gynecomastia with these drugs. So these are all things that you would need to tell someone that, oh, by the way, we're going to give you male menopause. You may have problems with erectile dysfunction. Your libido is going to be reduced. You might get small breasts. So that would be important education about these drugs. And lastly, the one other thing to consider is if you're reducing testosterone with any of these drugs, you're actually reducing testosterone stimulation of the bone marrow, of the bones, which males rarely get osteoporosis. and that's because of the testosterone we have. But if you're blocking the testosterone or reducing the production, you're more at risk for osteoporosis with these drugs. Okay, so that's that little section. I think it's important to know those for just for your general knowledge, because you'll come across these drugs, and just to have an idea of how they work. So let's go on to tamoxifen. So we're still in the hormonal group. So tamoxifen is an anti-estrogen. Okay, so it's in a group called selective estrogen receptor modulator. Okay, that's a long term. But basically at the breast, so this is a drug used for breast cancer. So how does it work? Well, it blocks the estrogen receptor from being stimulated by estrogen. Okay, so at the breast, it should slow down the growth of estrogen positive breast cancers. So we test the cancer, we see if the cancer is sensitive to estrogen, and if it is, we would use an estrogen receptor blocker such as tamoxifen. Okay. So if someone has breast cancer, they may still receive treatment in the form of chemotherapy and radiation therapy and surgery, but then they if their estrogen positive, if their cancer is estrogen positive, they would also be given tamoxifen as an ongoing treatment orally to really make sure that the estrogen that's circulating in the body doesn't have the potential to stimulate the breasts to potentially have a recurrence of the breast cancer. The other thing it's used for is prevention of breast cancer in women that are at high risk. So if there's a very strong family history of breast cancer, your sister, your mother, tamoxifen has also been used to take it preventatively, even though you don't have breast cancer, because you're considered high risk due to your family history. Okay, so we're talking about so that we can use it as a treatment and as a prevention of breast cancer. Okay, can also be used to treat male breast cancer. Okay, if it's estrogen receptor positive, just remember that tamoxifen is an anti-estrogen used in breast cancer. Okay, so if it's an anti-estrogen, this is a bit of a weird drug. So we'll come across a couple of things that I'll explain, which may not make sense at the beginning. So it binds estrogen receptors, causing an anti-estrogen effect at the breast level, right? So it stops the stimulation of the cancer cells. Okay, perfect. The adverse effects, and I think you should know these. So why all of these other ones? Well, let's start with the menopausal symptoms: hot flashes, vaginal discharge, irregular periods, vaginal bleeding. Okay, so it's an anti-estrogen. So in other parts of, if you can think of what happens if you turn off the female estrogen cycle by being an anti-estrogen, you're going to have menopausal symptoms suddenly, like upon taking this drug. So you'll come back and say, listen, I have hot flashes, I got irregular periods now, I don't have any sexual desire. So we've basically made someone develop menopausal symptoms because we're blocking their estrogen. Okay. So now here's where it gets a bit odd though. In the uterus, this particular drug acts as an estrogen stimulator. So it stimulates the estrogen receptors in the uterus. And I'm telling you this not to confuse you, it's just so you can understand the adverse effects. So I told you in the breast that it's an estrogen blocker at that receptor, and in many tissues of the body it makes you menopausal because it's an estrogen blocker. Okay. In the uterus, it stimulates the estrogen, that particular receptor that happens to be in the uterus, so it causes the cells to divide rapidly in the uterus. And so we always have to think of, there's a potential to produce uterine cancer because you're stimulating the uterine tissue with tamoxifen. So one of the advices that we give women, especially postmenopausal women that are on this drug, is if you ever get vaginal bleeding, that would be a concern. We would need to see you for that, because that could be a sign of uterine cancer. Okay, so we're treating one cancer, breast cancer, but we're taking a bit of a risk, not a big one, but a bit of a risk by increasing the chance of uterine cancer. Okay, another part of the body that is affected in a positive, well, not a positive way, so the vascular system. So there's an increased thromboembolic, so increased chances of DVTs and PEs, because tamoxifen acts on the blood in a different way as well. So on the vascular system, tamoxifen acts as a stimulator of estrogen receptors. And estrogen, as we may know from, say, birth control pills, they put you at risk for, there's a slight increased risk of DVTs and PEs, pulmonary emboli. So being on estrogen, whether it's in a birth control pill, or in this case tamoxifen, puts you at a slightly increased risk of DVTs and PEs. So the short answer for this adverse effect is it depends which tissue we're talking about. So if it's the breast, yes, it works as an anti-estrogen. Menopausal symptoms, anti-estrogen. Stimulates the uterus, that's why you get the potential side effect of uterine cancer. DVTs and PEs, yes, because of the stimulation. It acts as an estrogen. It's very odd, I told you. So I hope that helps you understand those side effects more, just because of how the tamoxifen, what the tamoxifen is doing. Okay. Contraindications. Well, we wouldn't use this if you have a history of DVTs or PEs. Definitely wouldn't use it in pregnancy. And you know, if someone's being treated, they're on warfarin or they're on some kind of blood thinner for a DVT or PE, like long term, we wouldn't add tamoxifen to that, but just because of its potential to thicken the blood. Okay, I hope that helps. Now, I just wanted to tell you, I purposely chose tamoxifen because I think it's the most important one in this entire group. If you look at the other groups quickly, aromatase inhibitors, well, those are just drugs that stop the production of estrogen in the body. So, you know, there was a drug, tamoxifen blocks it at the receptor site. We had one of those for prostate cancer, and we also had drugs that actually reduce the production of testosterone. This drug, anastrozole, not as commonly used. This reduces estrogen in the blood. Okay. Tamoxifen is a much more commonly used medication. So I didn't talk very much about this. And the other ones, I don't think you're going to come across. Raloxifene is actually a medication used for osteoporosis. And the other ones I'm not going to get into at all. I really think try to keep to the prototype drug. So tamoxifen is the main one. Maybe know a tiny bit about anastrozole. I don't think it's as important though. Okay, so again, we just spoke about hormonal type treatments for certain cancers like prostate and breast. And then these are biologic response. So how can I give a drug to affect your biologic response? Um, how can I boost your immune system to fight harder? And the targeted therapies. So the biologic response, first one that should come to mind is interferons and interleukins, right? Those are biologic response modifiers, and they make the group called cytokines. Okay. Now, the monoclonal antibodies should really be considered more in the targeted therapy. Okay, so maybe just consider the monoclonal antibodies, which are not interferons or interleukins, those are cytokines, under targeted therapies. And when we've gone over the monoclonal antibodies and how they target a specific antigen, and then attack directly that antigen on the cancer cell, where then the body recognizes this antigen antibody complex and destroys it. So these are relatively new. They're becoming more and more popular. We're discovering more and more of them, and companies are making many more of them for different conditions. The other ones are really other ways to affect receptors or enzymes, or the blood flow going to a cancer. I'm not going to spend time talking about these. These are mentioned in ATI. Would I spend hours going through these? It's not realistic. Remember, keep to the prototypes. And the prototype here, under the biologic response modifiers, interferon and interleukins, and in terms of the targeted, it's the monoclonal antibodies. Okay. I think the other ones they're mentioned, yes, but it becomes very confusing if you're trying to memorize sentences for each one of these. So if you're keeping to the prototypes, I think it'll be much easier on you. Okay, so adjunct treatments. So before we start this slide, see what happens is I forget to say something on the slide before, but then if I try to go back to that slide, and I start recording, then it removes the part that I've already recorded. So anyways, so just keep those categories in your mind. Okay, the cytotoxic agents, and we spoke about 4 or 5. The non-cytotoxic agents, and in that group there was the hormonal agents or the anti-hormonal agents such as tamoxifen. Then there was the biologic modifiers. You will have heard of those already, the interleukins and the interferons that boost the immune system to fight harder. And then the very targeted cells. And I think just as a whole, just understand that these are just, we're trying not to impact the human body while having a big impact on the cancer. And those are your monoclonal antibodies and some others that were listed there. Again, I don't think memorizing each esoteric one of those, like tyrosine kinase inhibitors and all that, is to your advantage. Understand the bigger picture is what's gonna help you. Okay, now, so adjunct treatment. So this is a list of other things that need to be dealt with in someone with cancer and undergoing different forms of chemotherapy. So pain. So typically pain is addressed with, if it's mild pain, it can be addressed with acetaminophen and sometimes with non-steroidal anti-inflammatories. But often cancer pain isn't mild, so we need to use opioids, narcotics, to deal with the pain. And we don't tend to get too worried about addiction when we're dealing with cancer pain, okay? It's really a matter of getting the pain under control. It's real pain that needs to be addressed with an opioid, a narcotic often. Tolerance. So tolerance can definitely happen with opioid narcotics. And sometimes we have to increase the dosing of the narcotics to have the same effect. Fatigue is very common in cancer. Not only can many cancers give you the symptom of fatigue, but the chemotherapy agents sap you of a lot of energy. Nausea. These chemotherapy agents are extremely nauseating. They really hit the gastrointestinal tract. So we need to use different medications, right? And a very common one in cancer treatment, and also now it's become mainstream for nausea and vomiting in the emergency room and in inpatient wards, is ondansetron, which is Zofran. Okay. Mucositis. So oral ulcers, inflammation in the mouth, making it difficult to swallow. We make all kinds of different solutions. A lot of them have lidocaine, so liquid lidocaine, viscous lidocaine, that will also mix up with diphenhydramine, which is Benadryl, and sucralfate, which is it's an anti-ulcer medication, and it forms a paste in the mouth and protects the mucosal lining. So that can all be made into one solution called a GI cocktail to comfort people with oral pain. Anorexia, so lack of appetite in cancers, very common. And also on top of that, the chemotherapy really makes you lose your appetite. So sometimes we'll use corticosteroids. Corticosteroids such as prednisone or dexamethasone, can stimulate appetite. So some cancer patients are on those. If anyone has had to take a corticosteroid such as prednisone or dexamethasone, if you've been on it for more than a week or 10 days, you realize that you are definitely hungry. It definitely stimulates appetite and weight gain. Thrush. So thrush is candidiasis in the mouth, right? So why does that happen? Well, your immune system is being hit by the chemotherapy agents, so that you can get overgrowth of Candida albicans in your mouth and develop those white plaques of thrush, which needs to be treated with an antifungal, which typically oral mycostatin, so liquid mycostatin that you put in your mouth to treat the thrush. You can get intestinal infections. You can get a whole lot of diarrhea as well with the chemotherapy that's being given. Mental health issues, right? So your way of life is definitely changing. Your concerns for the cancer, your frequent appointments, coping with the chemotherapy, dealing with potential loss of income. So there's many issues with mental health when it comes to cancer. Dirty laundry and end of life care. I'll I'll stop there since I can see I'm adding up the time. This is just a map of marijuana and the legalities of it in the United States. It's fully legal in Canada, whether for medicinal use or for recreational use. But in the United States, it just depends on which state that you're in. But just to say that marijuana can have a lot of positive aspects in the treatment of cancers. So it can help pain, it can help fatigue, it can definitely help nausea, and it can help anorexia. It can stimulate your appetite. So for anyone who's tried THC, you know it stimulates appetite. So it's used for many of these on the list here. Okay, so let's talk about ports and PICC lines. So as you may recall, when you're receiving chemotherapy or any drug that you're receiving for a prolonged period of time, do you really want to get an IV every time you go to the hospital? Not really. It's painful every time, and other times they have difficulty accessing a vein and they have to poke you 3 or 4 times. So there's different systems, especially with chemotherapy agents, where many of them are vesicants. They're very toxic to the tissue. And you really don't want that IV to go interstitial, meaning for it to come out and then the fluid to leak in the surrounding tissue. So we've come up with port systems and PICC lines, and so basically a port is a little implantable reservoir with a catheter that gets tracked under the tissue into into a vein. It goes into your central system, right? It's typically over your chest that you have a port, so you will feel a little bump there, and there's a mesh membrane. There's a membrane that can be accessed to either infuse medications. So you can see in this picture that the port is being accessed with a needle, but you can also access blood through a port. So you can do blood tests, you can infuse medications such as chemotherapy. So, and also for the patient, it makes life much more bearable. There's nothing externally which is above the skin, such as in an IV or even a PICC line, which we'll come to. Everything is below the skin, so it's not like you're limited by something that's sitting on your skin, right? This is below the skin, so it makes your life routine really much easier. You don't have to change as many things. You don't have to be thinking of this port that's below your skin. And there's a lot of other advantages. So you can, if you get dehydrated from your chemotherapy, from all the diarrhea and vomiting, the port can be accessed to be given to receive fluids. You can receive an assortment of different transfusions through the port. You can have all your blood draws for all the blood testing you need through the port. And so you're not getting poked all the time for an assortment of tests and administration of drugs. Now, just remember that there's a silicone membrane on top of the port that the needle goes through. So you can't just use any needle for these. You have to use non-coring needles. Okay, these are referred to as Huber needles. And the reason for that is if you're just using regular needles, you're going to poke holes in this membrane, and the membrane will quickly break down. These non-coring needles, they don't destroy the membrane that you're going through. They don't create cores in it. Okay, so that's really important to know when accessing these ports. Okay, so now let's talk about PICC lines. So peripherally inserted central catheter. So this is like a very long IV. Okay, it's probably about a they're about 2 feet long. These things, when you pull them out, you wonder when it's actually going to end. It just keeps on pulling out. And there's nothing fancy about removing them. It's just like removing a very, very long IV. But this PICC line is inserted so that at the other end of it is actually in your central circulation. And we'll actually do a chest x-ray to see where the end of the PICC line has ended up. And it's usually in your superior vena cava, somewhere in the central circulation. And that's really good when giving chemotherapy agents, because a lot of them are irritating to small veins. And they cause phlebitis, which is inflammation of veins. So when we're giving chemotherapy agents, if they're ending up in the central circulation right from the PICC line or the port, then you're not destroying or damaging little peripheral veins with an IV. Okay, so these can be used just like a port for prolonged periods of time. For chemotherapy, sometimes people need to be on months of IV antibiotics for certain conditions, so they can be used. For that. As you can see, it's not as big of a procedure as a port. Not that a port is a big procedure, but look what you end up with. You end up with external lines here, right? So it's not quite as protected as a port, which is completely under the skin. So these have potential to get infected, right? Just like any foreign substance in the body can get infected, these lines can get infected, and they can get clotted. So the line can get clotted, the tip at the end can get clotted with blood, and that can happen with the port, by the way, as well, right? It's a foreign, it has a much lower chance of getting infected because the whole thing's underneath the tissue, underneath the skin, but they can get clotted as well, right? The tip ends can clot off, and there's various ways of trying to unblock them as opposed to just pulling them out. But just remember, infection and clotting within these are definitely possible. So this one is showing two lines that can be accessed for different medications, or maybe you're giving intravenous fluids for one. These are typically well bandaged, so that, I mean, it would be pretty hard to pull out the whole thing, but you wouldn't want it to be pulled out at all. Okay, so those are the two systems that are used when requiring ongoing treatments, typically for beyond 2 to 3 weeks. So PICC lines and ports. Okay, so this is just showing you an image of tissue that's been exposed to chemotherapy. And as you know, we mentioned a couple of chemotherapy agents that are vesicants, right? So if that IV were to go interstitial and was not noticed for a while, and a lot of the chemicals got into the tissue, then it necroses, it kills the tissue. Okay, so big advantages to having a port or a PICC line over a typical peripheral IV. for chemotherapy.